Hello, Insta family. It is Dr. T here on a Wednesday night coming to you with our live Q&A. And I've actually got a really great topic to start with. I want to give a massive shout out to Tanya. Thank you, Tanya, for asking me this question in a consultation today. And I actually thought, you know what, that would make a fabulous live. So I'm actually going to talk to you about some of the things that can go wrong in an IVF cycle. I know that's not very glass half full, but I think this would really help, particularly partners, because often in an IVF cycle, partners watch their partners going through the IVF process and there's not a lot that they can do. And sometimes it can be quite distressing, particularly if things go a little bit wrong. So let's talk through it in stages. Let's try and chunk this down a little bit. So the first stage of our IVF cycle is when we do controlled ovarian hyperstimulation. So that's where we give you the drugs. You start on about day 2 or day 3 after the nurses have said, yep, you're good to go. And what we're trying to do is recruit the whole group of follicles to grow up really big. So they start at that 0.5 centimetre and they all grow up to around about 2 centimetres each. So, you know, your ovaries start at this size and they end up at this size. But one of the main complications that can happen is ovarian hyperstimulation syndrome. And that's literally where we open the gate way too wide and you recruit up a lot of follicles. Now, each of those follicles, once you have ovulated, or once those eggs have been collected, those follicles will produce a chemical called VEGF. And what that does is make your vessels in your body very leaky. So all the fluid in your vessels leaks out into third spaces. So that includes things like into your abdomen, so you can get ascites, or into your chest, you can get fluid on the lungs or even around the heart. That can also cause a relative dehydration in your blood vessels, increasing your risk of getting clots in the legs and the lungs. So ovarian hyperstimulation syndrome is actually a really big thing. And there are things we can do before the cycle, during the cycle, and after the cycle to reduce your chances of getting it. What's your chance of OHSS? Around about 1%, but there are certain populations that are at increased risk of that. Those who have a really high egg count, AMH, antral follicle count, and those who have been diagnosed with PCOS who might be going through IVF. So we can choose individual doses of our Gonal-F, Puragon, Menopur, or the drugs that you can have. You can choose individual dosing for that, depending on, say, what your AMH or what your antral follicle count is, and there's a number of individualized algorithms that can be used. We can use something called an antagonist cycle, so you'll get Cetrotide or Galutran as part of your cycle. We can change the type of trigger that you get, and we can freeze all the embryos and not do a fresh embryo transfer. All of those things will reduce your chance of developing OHSS after your cycle. So that's probably the main, complication associated with ovarian stimulation. Then you've got your trigger. What could go wrong with the trigger? Well, it could be, so we base our trigger to egg collection time on the average population. It may be that you're not average. And so when we go to do an egg pickup, it might be that your follicles have not matured and we're collecting all immature eggs. Or we might find that you've actually already ovulated. And so by the time we get to the egg collection, none of the follicles are there, or perhaps the follicles have already ovulated and there's lots of free fluid in the pelvis. Is it a complication? No, not really, but is it an unexpected outcome? Yes, and that can be really challenging to experience. What about the egg collection itself? Well, that's probably got the most complications associated with it because it is a surgical procedure. And I guess that's the main thing I want you to understand, is that IVF is not without risk, and particularly during a surgical procedure. So any surgical procedure has a risk of anaesthetic. The risks of anaesthetic are extremely low, and generally in a well, healthy population, and they're the sort of people going through IVF are well and healthy, or we certainly try to optimize you before you go through IVF. But there are risks of anaesthetics. There are risks associated with any surgical procedure that are generic, like bleeding, infection, pain. Again, all of those are quite low risk. Damage to organs that are in the pelvis near where the ovaries are. So that could be the ureters or the bladder or even the bowel. So surgical risks around about 1 in 500. So that's a pretty low risk. And again, we will attempt to identify the things that might increase your risks. So for example, a female who might have overweight or obesity is going to be at higher risk of surgical complications just due to it being a more physically difficult procedure. That's one of the reasons why we encourage you to lose weight before we proceed with IVF. It might be that you've had pelvic surgery for something else, endometriosis, maybe you had an appendectomy, increases the risks of scarring in your pelvis. Might be that ovaries are stuck to things like bowel or even blood vessels. So the risks are there, but we will try to mitigate those as much as possible before we even go for egg pickup. In saying that, the vast majority of females that go through an egg collection are absolutely fine. Pain relief afterwards. We generally will discourage you from using anti-inflammatories if you're going to have a fresh embryo transfer, but simple analgesia is often enough. But of course, we can give you whatever you need to make sure that your pain is under control. What other complications can happen at the time of, an embryo transfer? It might be that it's very difficult to get the transfer catheter through the cervix. Perhaps you've had surgery on your cervix before, maybe a LETS procedure. Perhaps you've had lots of procedures on your cervix, like multiple embryo transfers, maybe hysteroscopies that's caused scarring in the canal. And it might be that we fail to actually navigate the cervical canal, and so we have to abandon an attempted embryo transfer. It doesn't happen very often at all. Are we likely to perforate the uterus? No, we do it under an ultrasound guidance. Are we likely to introduce infection? No, although we don't use a completely aseptic technique, we certainly identify those who might be at risk by doing STI checks in your screening. But all of those risks are extremely rare. And then there are risks associated with pregnancy. So the main one, and this comes to another question that I was asked, and that is the risk of ectopic pregnancy. So ectopic pregnancy is where the embryo implants outside the uterine cavity. So ectopic can be in the cervix, it can be in a cesarean scar, or it can be in the tube. Now here's the crazy thing. People who undergo IVF are, compared to the background population, at increased risk of having an ectopic pregnancy. Even though you're putting the embryo through the cervical canal and into the endometrial cavity, they are at increased risk of ectopic pregnancy. One of the main complicating reasons for this is that many people undergoing IVF are doing it because they have some other pathology, like endometriosis, like tubal blockage, and those things themselves are going to increase the chances that that little embryo is going to go and implant itself in the tube. It may be someone with decreased endometrial receptivity, means that those embryos just don't want to implant in the lining, they want to implant somewhere else. So that's one of the other things that we keep an eye out for, is that slightly increased risk. Now, the background risk of an ectopic pregnancy is around about 1%. If you've had an ectopic pregnancy before, it goes up to about 3 to 5%. But that means that the vast majority of pregnancies that you will experience will still be intrauterine. So, you don't need to stress too much that if you've had an ectopic pregnancy before, you're almost guaranteed to have another one. No, but you certainly would be under surveillance. So, yes, Michelle, thank you for jumping in there. Embryo arresting on the day of transfer. That's a devastating outcome for people. Sometimes not getting any embryos to transfer on that day 5 or that day 6 can be really, really distressing for people, particularly if there's nothing to put in the freezer, or you're doing a frozen embryo transfer cycle, for example, and you've done all that work and then the embryo fails to thaw, for example. So all of these things are challenges along the way and can be incredibly psychosocially distressing for either the patient themselves or even their partner. So I'm hoping that that's going to be, without being too scary, I'm hoping that that has been a little bit more insightful for you in those of you who are thinking about progressing with IVF or perhaps are on their journey with IVF. So that was a really good question, and I think I also managed to address the question about increased risk of ectopic pregnancies, which is a really good one. Somebody else, and feel free to drop some questions into the comments section if anyone wants to ask some questions along the way. Someone else in direct message asked me the question about, look, what's the difference between day 2, day 3 transfer and day 5 embryo transfer? So the first thing I want to do is just clarify the difference between the two. So a day 2-3 embryo transfer is when you are transferring the embryo much earlier in its development. So day 3 is about cleavage. So you've got around about 6 to 10 cells that have divided in that embryo at day 3. Extended culture, or day 5, day 6 blastocyst transfer, is when the embryo has continued to develop right out to blastocyst stage. There's about 100 cells in that embryo, and it's already started to differentiate into the inner cell mass and the trophoblast trophectoderm cells on the outside. And there's a little blastocele or little bubble that you see in the middle of the embryo. So they're very different stages, and in fact the embryo in spontaneous conception happens in the tube, and it travels all the way down the tube and will actually arrive into the cavity when it's at that blastocyst stage, so day 5, day 6. So in fact the endometrium is most ready to accept an embryo at that time, and so biologically it seems most plausible to transfer at blastocyst. And in fact, the evidence shows us that you get a higher implantation rate and a higher pregnancy rate in normally responding populations if you do extended culture and blastocyst transfer. So that's why I always advocate a blastocyst transfer. But what about our poor responders? They're the ones that we sort of go, oh gosh, should we do day 2, day 3 in case they don't get a transfer at all? It's better to put the embryo back in the cavity where it belongs as opposed to the environment in the incubator. And that's somewhat debatable. So the first thing I want to do is clarify what a poor responder is. It's a terrible term, isn't it? But poor responder is somebody generally that will have less than 6 eggs collected. Now, there are expected poor responders, and they tend to be older women or women with a low ovarian reserve. We expect them to have a low number of eggs collected. Then there are the unexpected poor responders. So these are women who have a really good ovarian reserve, but with stimulation, they might only recruit 3, 4, 5 follicles. They might only get a couple of eggs collected, and that was an unexpected outcome. And that may have something to do with the stimulation protocol that was used. But as many of you know, going through IVF, you get a progressive decline in the number of embryos that continue to develop. There's that attrition that happens. And so there's a very real possibility that, but as Michelle said before, by the time you get to that blastocyst stage, you have nothing to transfer. Is that necessarily a bad thing? Well, some would argue that by transferring at day 2 to day 3, you may be creating a false sense of hope in that those embryos were probably going to arrest after that day 3 cleavage stage, because that's when the embryonic genome kicks in, and that's when we really assess whether or not we've got an embryo of decent quality. So by transferring at day 2 to day 3, you're really not able to assess the embryo quality. You're really only being driven by the egg itself, or the sort of ultrastructure of the egg. So maybe they were not ever going to have a pregnancy anyway, and we're doing a transfer for the sake of that patient getting a transfer. Is that necessarily a good thing? Maybe. Maybe a patient would like to have that hope of having a transfer, or maybe we need to be a little real in that we're not actually going to be able to culture embryos to day 5 for them, and perhaps we need to look at another alternative for moving forward with the family. So sometimes it can be very helpful to do extended culture so that we can help patients make decisions about moving on with treatment. The evidence seems to suggest that there's probably no significant difference between transferring at day 3 versus transferring at day 5 as far as pregnancy rates go. What is that? How do I interpret that? Well, if you do fall pregnant from a day 2, day 3 transfer, you were probably going to fall pregnant if you had allowed that embryo to culture out to day 5. That's the reality, and that's what the data seems to suggest to us. So it is my practice, and others may choose to do it differently, but it is my practice to encourage my patients to do extended culture. If I'm in a situation where I can do continuous culture, so not having to take the embryo out of the incubator to assess it, say a time-lapse machine where we can watch it in incubation continuously, then it would be my preference. Oh, there's the dog. It would be my preference to offer someone extended culture to help them either achieve that pregnancy or to help them to move on with a different treatment plan and get pregnant, which is ultimately what they are wanting to do. So a little bit long-winded, I'm sorry, but I felt that it's worth explaining as to why I have that discussion. Would I deny someone a day 2, day 3 transfer if they wanted it? No. As I said, the pregnancy rates are no different, but in that particular population. But I would question, if they were not pregnant, whether or not it would be a good idea to do that the next time or move on to extended culture. Okay, Jules, Catherine, is there a difference in intramuscular progesterone versus pessary progesterone in a modified HRT-FET? There is some evidence to suggest that those who may be... Look, the standard of care, let me reverse this. The standard of care is progesterone pessaries, and the pregnancy rates in low-dose stim versus HRT versus natural cycle are probably no different. But there are some people who are progesterone deficient, or they might not absorb vaginal or rectal pessaries particularly well. And in fact, the traditional way of giving progesterone was intramuscular. But there is a complication of abscess formation, and it's very, very painful. So ideally, we don't do intramuscular progesterone if we can help it, but there are some patients who need it. I think my family are starting to go a little bit crazy in the background here. So I'm going to wrap this up really quickly. Michelle, I've addressed. Any other questions? Talking about realities is valuable. Yeah, it is, Michelle. I think it really is valuable to talk about it. Oh, staff are mama me. This is my last question, guys. Does the chance of a live birth increase with each failed cycle? I'm not sure if you're talking about a frozen embryo transfer cycle, so from one stimulated cycle, or if you're talking about subsequent IVF cycles. So the reality is that the more IVF cycles that you do, fresh IVF cycles that you do, the lower your pregnancy rate is going to be with each subsequent cycle. That's the reality. I mean, in Australia, women do on average 2 cycles each before they get pregnant. But the reality is the more cycles that you do, you have a lower pregnancy chance with each subsequent cycle. If you are doing frozen embryo transfers from one stimulated cycle, and you might get 3 embryos and you transfer 1 fresh and then you put the others in the freezer and come back if you're not pregnant, with each cycle your pregnancy rate goes up, and we call that a cumulative pregnancy rate. So in one IVF cycle, if you've had 3 transfers, your third transfer, you're going to have a higher pregnancy rate than you do your very first one. And so that's how the statistics work, because we work on a cumulative pregnancy rate. So I'm hoping that was helpful. Statistics can always be a little bit complicating. The most important thing is communicate with your practitioner, talk about your chances of success, and don't give up, guys. Don't give up. That's it from me. I'm signing off. Hopefully those answers were helpful to everybody. Lovely to have you on. And I will see you again soon. Ciao.